Welcome, everybody, to the HHQI's Underserved Population Networking webinar. I'm Misty Kevich, one of the RN project coordinators with HHQI team, and also joining us today on the call is Crystal Welsh and Sharon Miller, who are also RN project coordinators. We have Misty Dyke, who is our communications specialist, and Andrea Lefke is another one of our specialists on our team. So we want to thank you for taking time out today to attend today's webinar entitled Life Maps, Treating the Whole Patient, Not Just the Disease. Today, our featured speakers are from All About You Collaborative Healthcare Services with locations in Connecticut. The agency was featured this summer as a success story called A Patient-Centered Approach to Home Care, and it was highlighted in our Fundamentals of Reducing Hospitalization Best Intervention Package, which we call BPIPs. The success story really focuses on their innovative program that they have created to address issues and barriers of very complex patient populations. The Life Maps model was created and has been very successful for them in improving their outcomes, reducing hospitalizations, and emergency department visits. Today's session, there are 1.25 hours of nursing CEs, and we will give you information at the end. You will watch the webinar, and then you will be logging on to HHQI University to complete an eval and a reflective question. It will only take you 15 minutes. I'll tell you more about it, but I am so excited to introduce you to our two speakers today. Rick Sales and Yvonne Gamlin are RN, and she's an RN, are the owners for the managing partners of All About You Collaborative Health Services. So for 16 years, they've recognized the importance of collaboration across the continuum. Because of their focus on quality and patient-centered care, Yvonne and Rick have successfully developed an effective care delivery model that promotes collaboration across the continuum and supports their vision. Together, we can make a difference in the lives of our patients. Despite caring for those very complex patient populations that include behavioral health, the agency continues to demonstrate a decrease in their Medicare hospitalization rate below the national and state averages. In addition, they have obtained preferred provider status for several hospitals in their demographic region. They do have several offices in Connecticut. Yvonne began her career as a CNA, and then a few years later, she obtained her RN license and quickly became an RN case manager and supervisory roles within an organization. And about 2 years after that, she became the co-owner and manager of All About You Collaborative Healthcare Services. Now, over the years, she's been involved in many different legislative and a lot of collaborations within their state. They are looked at as very innovative leaders within the state of Connecticut and nationally. Rick has began his career in home health related to finance. He joins with Yvonne as the co-owner and managing partner of the agency. He brings to the agency his strong financial and technology experience as the agency CFO. He's very active in his community, including supporting local breast cancer awareness initiatives, the Senior Center, and also the Chamber of Commerce. And because of his honesty and integrity, he has gained the respect of both employees and colleagues alike. So it is this strong collaborative and continuum that they continue to excel within the organization. So I'm going to turn over the presentation to Yvonne and Rick.
Thank you very much for that description. I appreciate this. So Life Maps is a patient-centered model. We plan ahead, not in crisis. Life Maps is a model which focuses on treating the whole patient, not just the disease. In order for an individual to be successful in reaching optimal wellness, personal support, safe living, psychosocial support, and community support must be in place. Life Maps model here, the personal support can be a family member, paid help, an elder law attorney, a financial advisor, state advocates, agency on aging. Safe living support can live in at home, a paid family support, assisted living, skilled nursing facility, senior living community, and the psychosocial support can be a senior center, a veteran center, a church, a senior outreach program, support group, or it can be a group that helps with depression, anxiety, or PTSD. Community support is home care, Medicare certified, MD specialist or disease management clinics, and Medicare B house calls. It's the organizations that are within the community. What is a personal support person? It may be family members or close friends at the age 18 or older, or who are designated by the patient as a primary source of physical, psychological, or emotional and spiritual support. They are patient advocates who are treated as an active member of the healthcare team. They may provide with patient information or may act as the family spokesperson with permission from the patient. They may visit or live with the patient, may learn skills to provide hands-on care in the home. They may shop for specialty diet food or may pick up prescriptions, assure that the patient's overall needs are met, support the health education needed to reach or maintain the wellness, assures other parts of LifeMAP supports are met. Professional support services such as legal advisors, financial advisors, and state advocates are available for further assistance. What is a safe living support? It's based on the level of care needed. Private pay or family support can be 1 to 24 hours. A live-in can provide 24-hour care. Private pay live-ins usually require 8 hours of sleep. If around-the-clock supervision is required, 2 12-hour shifts would be necessary. Long-term care insurance will typically pay, otherwise it is a private pay service. Assisted living facilities provide care that may be paid for based on the level of support required. You may hire private pay, live-in, or shift care in addition. Home care that is covered by insurance or Medicare may also provide long-term care insurance may be subsidized. Skilled nursing facility is typically paid for by the insurance. While important, it's still being made. Long-term care insurance typically pays all or a portion. Senior housing may be subsidized by the Department of Housing and Urban Department, HUD. This may be less expensive than the above, but it does require private pay support if required. Home care paid by insurance can also be provided on the intermittent basis. What is psychosocial support? A change in health for an individual can cause challenges with everyday social activities. It is important to have resources for basic health care, but it is just as important to have resources to support one's psychosocial needs. Regular socialization is necessary for optimal well-being. Psychosocial support is provided within the community for anyone with a need, including veterans, individuals suffering from mental health, and seniors. It helps individuals and communities to heal psychological wounds and rebuild social structures after significant change in health. Early and adequate psychosocial support can be support those who suffer from depression, which can be caused by a significant change in health. Improve overall health. Help individuals cope with life stressors and resume their normal lives. Meet individual and community-identified needs. What is the community support? Community support services are groups that remain in the life of an individual and can identify when further services are needed. Home care services may continue to provide ongoing support under certain circumstances such as Medicare or Title 19, long-term care insurance, and private insurance. Medicare may pay for long-term support for those who meet the criteria. You can visit the Medicare Advocacy website for further information. And some private insurances may allow patients to receive services even if they're not homebound. However, private insurances have a cap on the other, and others allow visits certain amount of visits per year. Individuals may also pay privately if their insurances will not cover long-term support. Primary care physicians and specialists may also provide ongoing community support. So LifeMAPs as an action plan, you would identify a support person. Many individuals who are in the hospital or in the acute care phase have a hard time retaining or even hearing education that's been given to them. A lot of times we try to especially coming out of the hospital, provide a lot of education, and while they're acutely ill, they have a hard time obtaining this information, and the individuals just want to go home. So having the personal support person involved is intended to improve the education process while the patient is in the acute phase. To assure safe living in home, having the appropriate safe living plan in place will allow a safe transfer to home and assist in preventing hospital readmissions. Coordinate psychosocial support. It's intended to motivate the patient to want to get well and to want to manage their disease. A lot of times it's very difficult to try to get to the disease entity and to give education if the individual has anxiety or is depressed or doesn't have a reason to want to improve or follow the care plan. So this is a really important factor. Collaborate with the involved MD specialist and community resources. Communication and collaboration with community resources, especially the physicians, upon admission and even discharge or when there's a change in condition, is significantly important. It ensures early identification and implementation of resources to promote continuity of care, and allows the patient to be monitored long-term. This is a form that we have created and developed that you can actually write in the patient's name and identify the personal support person. In All About You, we actually add this to our 45, which is our care plan, and we identify if the personal support person is the first person of contact or is it the patient. This form can also be left in the home with your patient education or in a binder, and this is information that can be left with the physician's office. When completed, you have the full support that the patient requires. This is a map that we utilize for transitions. Life maps can take on a lot of forms, but most importantly, for transitions from a hospital to home or from a facility home, Life maps' purpose of having the personal support in place is to help with the coordination of all of these resources. When going from the hospital home and you have a personal support person to help the patient, you can give a clear plan and the support person can help that individual with this process. We also assure that the safe living, when going from hospital to home and dealing with home care, what DME supplies are required? Does the patient require oxygen? Do they require a lifeline? What type of safe resources, once identified that they're going to go home, need to be implemented within the home to keep them safe, free from injury. The psychosocial support, once they get home, is identifying first, have you had the right resources or connected the patient with the right resources to help them with the anxiety or depression that a lot of the comorbidities may cause, the change of their lifestyle. So usually social work or OT and working with the physicians can help with that resource. And then going one step further, what is the patient's interest? Do they enjoy the senior center? Do they enjoy the church? Do they like gardening? How can OT or social worker actually help modify a psychosocial plan for the patient if they're no longer able to, because of their disease, manage their diseases, able to reach their hobbies? And then the community support, identifying all of the physicians in the patient's life, all of the community resources. It's really important to collect information from all specialists. Many individuals have multiple comorbidities, therefore they have multiple specialists. I have an example of an individual that we utilized our Life Map plan in home care for an individual, a medical patient that had COPD, pulmonary edema, hypertension, PVD, insulin-dependent diabetes mellitus, macular degeneration, and he was the main caregiver for his wife. This patient had a history of frequent hospitalizations for exacerbation of COPD and pulmonary edema. We first identified the personal support individual, which was two of them. There was the granddaughter and the daughter. The patient was very independent, and like most of our patients, they did not want to put the burden on the granddaughter or the daughter. So when the granddaughter and the daughter came to the bedside, we were able to explain what their role would be, what the patient would want their role to be, and what they wanted to be a part of. And it was just clear explaining to the patient that while he was in the acute care phase, his worries were to be about how he can improve his health and give us the information while his family members can help us coordinate and maintain the information. The next piece was the safe living. He required oxygen, a walker, a cane, a lift chair, lifeline. We needed to provide education on a safe diet. He was high risk for aspiration, and he was eating peanuts and a lot of sodium. The caregivers put in the home. We also coordinated with Agency on Aging to get caregivers to put in the home so they can help him with his wife, which would help him be the husband and focus on his own disease process. The psychosocial support, he liked to play cards, and he was a veteran. He verbalized that he was anxious quite often, but as the nurse was working with the patient, they identified the amounts of prednisone that the patient was on for his pulmonary edema and COPD played a high role in causing a lot of this feeling of anxiety. That was communicated going into the community support with the multiple physicians that were involved with this patient, like the pulmonologist, the cardiologist, the primary care physician, the vascular doctor, and the endocrinologist. So at the end, after all of this was pulled together, with the family guidance and the social worker, they found him a group within his community who actually played cards. It was a veterans group. But like most individuals, this gentleman did not want to just go into a strange group. So the family worked with someone within that group that actually did an outreach and visited the patient at home, which made the patient comfortable to meet somebody within that group. And later on, once he was stabilized, was actually able to get out and attend these groups once a month or even more frequently and play cards. The safe living, the private caregivers were in place to watch his wife and take care of his wife and help with specialized meals, which resulted in decreased sodium intake, which decreased in COPD exacerbations and pulmonary edema. The next piece was the psychosocial, was the anxiety and the veterans group and the cards, speaking with the physicians about the prednisone and working with a plan to help lower this gentleman's feeling of anxiety. And once he knew what was causing the shakiness and the anxiety, he was able to work with this. The family being involved and hearing what his interests and what he really enjoyed then also began taking him to Foxwoods once he felt better. The community support, he continued with one time of nursing through the home care agency, and all of the nurse would coordinate all of the physicians that were involved with this patient. He went from going once a month to the hospital to every other week to 0 hospitalizations. The next patient I will present is our behavioral health high-risk population patient, which is about 75 to 80% of our population that we serve. Primary diagnosis of this patient was cancer of the neck and tonsils. The patient received a radical resection. He had a G-tube in place. He was totally NPO. He had COPD, chronic pain. He had a fall, which resulted in having an open reduction internal fixation of the left elbow and fractured 3 ribs on the right side. The psychiatric diagnosis was bipolar, anxiety, and depression. The patient had a significant history of hospitalizations, frequent hospitalizations. He was also had opiate abuse and benzo abuse. He was verbally and physically abusive to his wife. This was a very angry man. Due to many of the hospitals where we do not conduct bedside assessments at the behavioral health floors, so most of the conversations were happening over the phone. This patient has gone through several home care agencies which refused to take him back. The report that we received from the last home care agency was the patient was non-compliant, he was very angry, and he would not allow anyone in the home. Our psychiatric supervisor had contacted the patient, and with the first call, he refused. The supervisor asked if he could make a follow-up phone call. With over a week's time, the supervisor gained the trust and the rapport with the patient, able to communicate over the phone. The patient finally, after a week and a half, had allowed the supervisor to come to the home. The supervisor brought the nurse along with him, We were identifying the personal support person as his wife. At the time of identifying the wife as the personal support person, she expressed the situation that she was in, and she was looking for a divorce. The case manager worked collaboratively with the physicians and was able to get the wife into counseling herself and the patient in his own counseling. After a few months, the nurse, the patient, and the wife were able to get into couples therapy. In the meantime, the safe living arrangements were put into place where the patient's meds were put into a lockbox and the nurses were helping him with pre-pour and medication administration. After a month's time, the patient was taking his own meds once a week with pre-pours. Eventually, the patient was doing his own medications with the support of his wife and coordinating with all of his physicians, the oncologist, the psychiatrist, the pulmonologist. They were being taught on how to collaborate all of these resources. For the psychosocial support, it was the counseling that both were put into and then eventually into couples therapy. When asking the patient what it was he was so angry about, it was the change in his disease management. It was the change in not being able to eat any food by mouth. It was not having control over what he was facing during his health. The only control he had was the medications at his fingertips. But through counseling and frequent meetings, the patient and the wife reconciled. The patient's health started to improve. He then received a swallow study and was able to have the nurse, the medical nurse, and the psychiatric nurse conduct a joint visit that resulted in education on his modified diet, and the one thing the patient wanted to have was his Cocoa Puffs. So warm milk and crushing the cereal, he was taught how to have his Cocoa Puffs. In 1 year's time, it took a year's time to pull this process together through full life maps. The patient and his wife sold their house in Connecticut and moved off to Florida. A few weeks back, the patient sent a picture of him and his wife in the pool, and it was a success story of goals met. Life maps can also take in a process of community support. So we have a community collaborative program. All About You is involved in a few of them, but one that is my favorite is the Healthy West Haven Collaborative. We had developed a website for this community utilizing the Life Maps model. So a lot of the individuals who come to this collaborative were professionals and community groups within the community. This collaborative developed a COPD program, a faith community leader, a mental health leader, and a senior leader. And across the top, we have the personal support. So any of these professionals that needed to find a personal support resource within the West Haven community, they were able to click on this tab, and if you see down here are a list of all of the resources, and if you click onto the actual website, the name, it'll bring you to their website. So, yep, and then going back, we, if you go to the top, is the safe living support. So within a community, a list of all the safe community support are all of the resources within that West Haven community that are home care, skilled nursing facility, a live-in group, just as it would provide. And then at the top, if we go back, you can actually see the psychosocial support and, of course, the community support. So this is Life Maps in the form of a community model, which has been quite successful for physicians and community professionals to organize the resources that they need within their community utilizing the Life Maps model. And thank you very much for your time. This was the presentation for Life Maps. Maybe we can open up for some questions.
Well, thank you so much, Yvonne. I do have some questions that have come in and also some comments. So, and if you have not put in any questions yet, you can do so in the chat box that's on the right or the Q&A tab, and you can insert your questions. Do go ahead and put those in, or as soon as you think of something, we'll entertain as many questions as we have time for. I do want to make a couple comments before I start providing a couple of the questions. I loved when you were just taking a look at the West Haven, and it may have been on other slides, but I missed it. I love the quote at the very top, plan ahead, not in crisis. And I think that's a very telling story of what happens in home health, especially the population that you deal with, the very complex, those, I hate to say it, but the train wrecks that you get on Friday afternoon are, you know, sometimes the tip, correct? And so planning, even for patients that may not be in that train wreck status, is really being very proactive rather than having to react. So maybe you could start there with maybe a comment or two.
That's how it started.
Oh, sorry. Go ahead.
Yeah, that's how it started. We had, you know, having those patients that were coming out, and they would come out in crisis, and we needed to pull together all of these resources. And since we provide, you know, 80% or even higher of the high-risk population, we found the consistency of what model actually worked for us, and was having, you know, all of those pieces together. And those individuals who didn't have a personal support person, we had to find one in the community, whether it was agency on aging. There's a lot of resources within Connecticut that we pulled together, but we went to our aging resources to find a case manager and someone who can help the patient and walk the patient through this process.
Perfect. And what I also found, another key thought, again, I would like to talk about before we go to some of the Q&As, I just came back from Michigan, the state of Michigan, and doing, some of our team did a workshop there related to motivational interviewing, and that was a piece of what we were doing. And we were really trying to explain that many times there are barriers, and your patient might not appear to be non-motivatable, I guess that's not even a word, but unable to motivate them, or just do not see any vision of where we could go positively with a patient. So if we start to use some skill sets, and I think home health providers are awesome at doing this because we're in the patient's home, we can really see things that are happening, and we're good investigators, but we have to learn sometimes to dig deeper, looking for those basically Maslow's hierarchy of those basic need issues or safety issues, because the patient cannot work towards self-actualization or patient self-management until we can address those. Not that we can't start working on them, but we have to address those elephants in the room, and sometimes we don't know what those are. But by using, you know, a lot of open-ended questions, we start to learn, you know, through between words, looking around, we can learn a lot about our patients. In a lot of cases, those patients that do not look like you could motivate them or do any patient self-management, it's really because of those basic needs. And is that what you have found?
Absolutely. You know, when we first were getting all of these patients that, you know, a lot of agencies were sending over to us because we were basically the last road, we had to stop and ask why. You know, not just that the patient is non-compliant or the patient is not making it to their doctor's appointment or not going to their pulmonary rehab, and they can't get their meds refilled if they don't show up at their doctor's appointment. We had to stop and ask the question why. You know, why are they non-compliant? And, you know, as many will be aware of, that depression, clinical depression, can actually physically lock an individual. You know, they can't navigate their taxis or their rides or pick up the phone and call someone. They're barely holding on to the end of their rope. So as caregivers, your number one process is to develop the trust. And that may take weeks. It may take a long time, but don't give up on them. Call them, wait for them. You know, find the right person who has the ability to develop the trust, because trust is your number one skill.
Absolutely. The mutual trust is the key in making any inroads with disease management, patient self-management, and I think, again, home health is the perfect setting. We're on their turf. We are really involved in helping to make their lives better.
Correct.
We do have. Good. We have several questions that I do want to get to. I just kind of wanted to throw that in. Keep sending your questions in. They're very good. We're getting some really nice examples as well, and people are thanking you for the presentation and the information. I'm actually, while I go to ask these questions, I'm going to go ahead and go back to one of your slides. So let me just go back, because I think it'll be easier to look at this slide. Give me a second. I believe it's 4, yeah. I think this was a really good picture, and there is the plan had not in crisis. I missed that because I was busy looking at the points. So here's one of our questions. You've mentioned that you place the form, and that would have been, see if I can move to that one while we're talking about it. Oops, sorry. Well, I'm not doing a very good job here, so hang tight here. Find your form a second. Okay, yes. This form. You said you fill this out, and you place this in the patient's chart. Do you also include the life action plan in the 485?
Yes, we do. And we actually can put the Life Maps model on the 485. So you put the personal support person's name. Are they the first point of contact, or is the patient the first point of contact? And then the safe living arrangement is already on the 485 in your indicator, and one of the indicators for your safe DME supplies and what you put in the home. And then the psychosocial support is usually listed within your summary that indicates what the patient's interests are, but it can also indicate a part of your diagnoses, if it's anxiety or depression, you know, working with the physicians and what you're going to do for the psychosocial support first. And then your community support contacts, that's really important. That's a list of all of the physicians that are in the life of the patient and their phone numbers. We also include their appointments in their summary. So if they have particular appointments that they have made upon an admission. And then we also place this on our discharge summary so the physicians are aware of how they're left and what was pulled together.
Excellent, and these are great communication skill sets to show, again, that crossing the transition of care for everybody. That's excellent. I'm going to pick up on a comment you said there, but I'm going to go ahead and flip back to your model on slide 4 here. The question came in and said, what if there's not a caregiver? And I'm going to throw that out to you.
That happens a lot, especially with our behavioral health population. There isn't always a personal support person. So we ask the person first, though, is there somebody that they trust, someone who's willing? And if there is not, that's where, like in Connecticut, we have our agency on aging to see if that individual qualifies. There's also different advocates that are involved within the community that we look for. There is, with the agency on aging, they have their case managers, and we partner with them. There's the paid help. We try to do our best, and a lot of times it could also end up being that liaison. So the liaison is there at the bedside going through the education and then follows the patient home. It's not always fitting in a perfect little square, and home care usually doesn't, but we do our as much innovation as we can to find that person or to find a resource within your community that can help that person with the education.
Wonderful. And I'm going to make another comment here. I think looking at your West Haven site is an example, and we did get a couple comments about how that was a wonderful site. And I think what stands out to me, too, is the sharing of the community resources. It's an active, it's a live resource that's available to your whole collaborative. And when there are a lot of agencies that may have a list of the community resources, but they're not kept up to date. And we have a lot of agencies that are in the rural settings that have difficulties in getting social workers, or they have to share social workers amongst a couple agencies. And so, you know, as a nurse, if I had access to something like that, I think I would be able to better service my patients if there was a lack of a social worker.
Correct.
Okay. And so I do have another question, and I think you've kind of just touched on it, the process of your referral. And do you use the life maps with all your patients or just your complex patients?
We started with our complex patients, and we've integrated it now agency-wide with all of our patients. We even utilize it for our pediatric program.
Oh, wonderful. Another question, kind of going a little bit further into that, they said, you've mentioned that you've decreased your hospitalization rates. Has Life Maps made any progress with your emergency department visits in reducing the rate?
Right, and that we are working, it's so new right now, it's very difficult with the behavioral health. It's actually breaking the behavior. There's a lot of different resources or reasonings why our behavioral health population frequently frequent the ER. So I think that's where we're going to be working collaboratively with all the community resources to try to change that behavior.
Wonderful, wonderful. And it is an ongoing, evolving program. You've made such great strides in such a very short period of time, so it's very exciting.
Thank you.
And so I'm going to take another direction here with our next question. So how does your interdisciplinary team work together with each other, utilizing the Life Maps? Do you leverage your social worker a lot? And also they could tell that you use your community services a lot as well.
Yes. Coming from transitions, it's the liaison or the individual doing the bedside assessment that will start the Life Map process right at the hospital bed. When the patient is home or we have a referral from right into the community, it's the case manager upon their initial assessment that will start collecting this information. And the social worker and the occupational therapist play a huge role with the psychosocial support. The safe living support can be the physical therapist, occupational therapy, nursing. It's a multidisciplinary approach. And of course, the community support is led by the case manager, but the therapist involved have a role in that as well.
Wonderful. And we have another question related to the website, and we know that was an example of one that you had as a collaborative for the community. Can patients access the website they couldn't remember if they were able to, and if there were resources for them, or is it only for clinicians?
No, that is a public website for West Haven, but anyone, it's been up on LinkedIn within their group, and it's been on their Facebook. So the patients can access it if they can, navigate, the ones who navigate who are IT experienced. But it's utilized for anyone, actually, the physicians, the community, and the professionals. So anyone can access that website.
Great. And I think it's ideal for caregivers. I know I'm always a good proponent for even caregivers that live a distance away. Like my dad's 2 hours away, but, it's ideal if I would have information, being a distant caregiver, to be able to help support him since I talk to him on a daily basis. So it would be a really great resource of having that for patients' families that live across the country.
Absolutely. And those that we've identified through needs assessment surveys, such as transportation, that was the most difficult for individuals, we actually created a transportation tab in itself. So yes, we try to make it as user-friendly as possible.
And I'm glad you brought that up, because transportation is one of the critical areas or barriers that we find in healthcare for a lot of areas, both rural and urban. And I know you guys are very innovative, but it's a very difficult task to improve transportation, and you have rural and urban areas in the state of Connecticut. Can you talk about some of the maybe unique things that you might have tried or things that maybe didn't work so well?
Yes, we actually teamed up and work with an APRN house call program. So we have the APRNs that work with the physicians to actually come to the patient as opposed to the patient needing to get out for those who are really bedbound. And we've had, during our collaborative, the Healthy West Haven Collaborative, this isn't our collaborative, this was something that was pulled together by the community and led by Kathy Tynan. They were actually able, McKiernan, they were actually able to form the tabs, so they had individuals come in. So if you look at those tabs and all of those resources underneath it, those speakers have come in to speak. So we've had like logistic care and different organizations that provide transportation. They come in and do education on it, and we utilize it as a home care as well, as a new resource once they come in and educate our staff on that topic.
Wonderful, wonderful. And there are a lot of, religious, organizations. There's a lot of interfaith organizations that can also be reached out to. We just kind of, sometimes we're in that crisis mode and that reactive mode that that planning and having the resources available makes, it's a map. I mean, it would really be very beneficial for agencies.
Exactly, and that's what we've found, because when our nurses are dealing with an individual in crisis, to try to find resources at their fingertips, we do have wonderful resources like 211, and we utilize that, of course, but this is a little bit more individualized to each town or city.
Great, great. And how do you find your clinical staff satisfaction with the Life Maps model?
I feel that, like most agencies, our staff is wonderful. They love pulling this together, but, it's hard to capture in documentation. So honestly, we're working. I mean, this is evolving as we go.
Exactly.
So as we were having them documented on the 45, we just recently realized, well, we need to also have this on the discharge summary. So it evolves as it comes along, but they find it to be very resourceful for their patients in the area. And it helps, the social worker also helps guide them.
And I think from a personal satisfaction, I know the story that you told about the gentleman and his wife being able to eat the food that he wanted, and then ended up moving to Florida. And that was a couple that was going to, separate and divorce, and it was through discovering those barriers, creating, a good plan. So I know as a healthcare professional, it would give me such great self-satisfaction in the work that I'm doing.
Absolutely. I mean, I feel we were really lucky with this particular individual, because some of them just have that story that doesn't end well. But this group, this couple had faced for years this terrible situation, and really putting it together in a map kind of identified, she needed to find out what he was going through, and they both needed counseling. So focusing on that psychosocial support sort of pushed the nurse to have the insight to speak with the physicians and put this suggestion in place and work collaboratively with the community resources.
Okay, and I have another great question that came in, and how is the funding obtained for this wonderful multidisciplinary approach to keeping patients out of the hospital? Is it funded through cost savings?
We have not gone down that route. We've just utilized it. This is the first time we're actually sharing this publicly. This is just something that worked for us internally. So Home Care, our agency, has just implemented it as a personal model for our agency, and it worked. So this is why we would like to share it.
So it can be done under the regular home care payment system, and you're going to you're improving patient outcomes, not just hospitalizations, but I'm sure I know you've done a lot of work with COPD, because you've worked in a nice collaborative with your state QIN and QIO in the past, correct?
Correct, yes, and we've worked with different foundations like the COPD Foundation, and yes, COPD is definitely our specialty that we're working, especially with this model, and it's had significant outcome, because COPDers are a little bit more integrated, and they have introverts, and they have, depression, anxiety. So pulling this map together for someone who has COPD has shown us the most significant outcomes of all of our diagnoses.
So, and then this can tie into any of your disease management that you might specialize for, from a home health perspective. So I'm talking kind of to our listeners today, either on the live or the recorded broadcast. So the more that you're able to utilize tools, resources, models that work to improve outcomes for patients, it becomes even more cost effective because you're going to increase your referral base as well. You know, starting with the very difficult patients, that's how your agencies really got an inlaid, and now you have a wonderful collaboratives with many of your referral partners, correct?
Absolutely, and the end point of all of this that is also significantly important for a patient-centered, but is that we're not all specialists in our field, so it's really important to collaborate with your community resources. Knowing what community resources are out there and what insurance will pay for and how you can help the individual, you know, nurses need that at their fingertips. To help those professionals actually either come in the home or teach the nurse so they can provide the service.
Yeah, and I have another question that may fall right from there. It just came in. Are the services time limited? And I'm not sure if that's enough information for you, and I can ask for more clarity if need be. You're still within an episode of care, right?
We are. So, like, life maps can take a model from anything. It can be a hospital model. It could be a skilled nursing facility model. It could be a home care model. It can be a private provider model. It's just a model that can be used as long as the patient requires it. If the model is there and family members can look at this and say, okay, what do I need to do for my family member? How do I keep them home, or what do I need to do? If you look at this just sort of as a guide to help pull together the resources that you need, there is no time to it. It could be ongoing, it could change. It's just sort of a map to help guide you to pull all of these unbelievable amount of resources that are in the community that can be overwhelming in perspective.
Great. And now here's another I love these questions that are coming in, so please keep them coming. We'll take a couple more because we keep getting a little deeper here. So did this service model attract any ACOs in your area?
Yes, it has. We've worked with, you know, we're working with ACOs, and we've been doing this for the last 16 years. Our name is All About You Collaborative Healthcare Services to Survive, to take on those high-risk populations. So this type of patient is the patient that is costing the most money. And so if we can take this model and help those ACOs, we are definitely at the table and proud.
Wonderful. So again, you know, you're using resources that are allowed within the home care model to take on those most difficult patients. And as you expand territories in home health, that's usually the type of patients that you get, but you build upon this success. And it's really important to come back and continue to share that success back to that referral service, and that's going to continue to build and then continue to leverage. We know that Medicare, CMS is mandated hospitals by next year, 2018, that they have to have 50% of different payment models. And so we're going to be seeing more of the bundled payment models. We already have several out there already. We're going to see more ACOs. We're going to see lots of new models of care. So you have to make yourself different. Our patient population isn't going to get any easier. They're going to get more complex. We have over 10,000 new seniors each and every day with the baby boomers, and chronic diseases continue to rise. So, you know, the Life Maps model to me is really a good win-win in trying to continue to expand and stay with the future and expanding an organization, or something similar to it. But this was the model that you developed based upon the needs that you saw and the barriers. Correct, Yvonne?
Yes, our team, you know, we have a great leadership team here that as time was developing and we needed to implement different resources, we just had this vision and said, you know what, this is the commonality of the resources that we need to pull together. We're trying to educate patients in an acute care phase, and it's just not going anywhere because they're acutely ill. They don't hear what you're saying. And we have to be able to make sure all the resources are in place to keep them safe. And if you want to get them better, what makes them happy? What drives them? What's the psychosocial support that's needed? So yes, absolutely.
Wonderful. Well, thank you, guys. Hang tight. We're going to cover a few more slides, and if we have a minute or two, we'll handle another question. But I think we've handled lots of really good questions. Thanks to everybody that sent in questions. We do want to tell you a little bit more about some resources that can go hand in hand as you deal with this difficult population. We have an underserved population's best practice intervention package. As I mentioned, they're BPIPs. They give you that one is a very extensive package. It gives lots of resources related to many different factors on underserved patients. And also our Fundamentals of Reducing Hospitalization BPIP that came out this summer is also a good resource for you. We're very excited. I think this ties in beautifully, and it was not planned that way, that our next underserved population is January the 19th at 2 p.m. And the Alleghenies United Cerebral Palsy Service Coordination in Pittsburgh, Pennsylvania is going to be our presenting, and Tina Trimbath and Tammy Rhodes are going to be our presenters. And we're going to learn more about how to leverage those high-quality community-based services to improve patient outcomes and reduce hospitalizations for patients. Now, Yvonne just talked about that's a critical piece of the life maps is using the community services, and there may be many in your areas that you serve. But learning to recognize and search out for those that are higher quality that are working on improving patient outcomes, working on reducing hospitalizations is really going to leverage a greater partner and greater successes for you. So we're going to learn lots and lots about what they're doing. There is in the slide deck, you can register now by clicking the link, and we also have a subscribe to our HHQI's mailing list. We have an underserved population mailing list, but we have many others. We don't want to bombard you with information. We keep it very limited, and we've made it so that you can pick and choose what you want. It's somewhat newer, so we wanted to include that in the slide today as well. Now, for the CEs, for continuing education, there are the free 1.25 hours of nursing CEs, and you have to go to HHQI University. You can click on this link, or you're going to be sent there as soon as we leave. You're going to have about 15 minutes worth of activities to finish afterwards, and I'll tell you exactly what it is here. You needed to watch this webinar, which is an hour, and if you're watching live or even the recorded, you just did that. You will have to register for the course in the university. If you've never taken any one of the courses, you'll have to do a simple registration. I believe it's 4 or 5 questions, very simple. And once you're in, you're going to be able to register for the course. You're going to complete it, which is like a couple, just a welcome. Make sure you watch the webinar for an hour. You're going to get sent immediately to an evaluation that's built right in, a couple questions there, and you'll have a reflective question to think about what you heard today. And then once you're done, you're going to exit out, and you can download and print your certificate. So it's really going to take you just a few minutes afterwards. If you have any trouble or you know you registered for the university but can't remember your username, send us an email if you have trouble, hhqi@wbmi.org. I'm going to run through a couple slides so that you can see if you've never taken have used the university. There are tons of free nursing CEs. There are a couple courses that have PT CEs, and there is a course in there that has social worker CEs, which I think is appropriate, and it's on long-term effects of negative trauma, or the long-term effects of trauma, and it really ties nicely into the types of populations that Yvonne has talked about. But you will go to the university and you'll have to register, and if you forget your password, you know, there's a nice little send me a new password. You'll go into the underserved population course catalog, because it's set up just like a college. You find the course catalog, look around at courses. You go to into enroll with the little apple icon. You click on my account, and then you'll find a little green book, and in the view column, which is all the way on the right, and it'll start your course. Well, you'll have one more little book that gives you an action item there. And then the course is going to come up. You just follow through. When you're done, you exit out, and you have your certificate. Sounds harder on the slides because we try to break it down all into the steps, but there's easy to follow. There's also instructions that are available there as well. Or contact us. We'll be happy to help you out. So I think we are coming to the top of the hour, and I do just see lots of comments and thanking you, great valuable resources from everybody. I think I'll bring it right back to Yvonne and Rick to see if you have any last minute comments.
No, just thank you for having us, and we love HHQI. You just have such wonderful information, so it's an honor for us to be here. Thank you.
Thank you.
Well, thank you very much. And I thank everybody that joined us today. We value your time that you spend. Do come back for our January webinar. I think it'll tie nicely together to continue to increase your information, knowledge, and resources for caring for the very difficult patients with multiple problems. So we wish you to have a wonderful afternoon, and please complete the course information.